So we're going to introduce our first session for the day. So Dr. Foster has had the massive job of trying to cover paediatrics and all the revision that we need to know in a very short period of time. So thank you so much to Dr. Foster for taking on this topic for us. Dr. Foster is an F2 based in Birmingham at the minute. And a fun fact about Dr. Foster is she studied medicine in Southampton after completing psychology, a degree in Sheffield. She described medicine as a lucky mistake, which is very nice to hear. So I'll hand over to Dr. Foster. Thank you so much for joining us.
Okay, hello, I'm Kirsty. Dr. Foster, thanks, Danielle. I have the immense privilege of starting with you first, so thank you for joining. I will start in a second, don't worry. A couple of things that I just want to say before we begin. Congratulations on getting however far through medicine or whichever degree you're doing. Degrees are great, jobs are great, but they don't define you. These exams do not define you. If you pass or fail them, don't get me wrong, I want you to pass them first time and kind of sail through relatively easily. But if you don't, that's okay. Okay, these are not the end of the world. So I think once we realise and truly think it's okay, whatever happens with these, I just try my best. It kind of frees up your mind to actually do your best. And then there's just a bit less pressure on you. You know absolutely loads. I have no doubt about that. The fact that you're going through medical school tells me that you're knowing a lot. So have confidence in what you know. There's always going to be things you don't know. There's things I don't know as a doctor. I mean, I'm on GP at the moment, and sometimes I have to, when people leave, I think, oh, I can't remember that, but I know it's somewhere. And you have to look it up, and that's fine. So fear not, you cannot know everything and you will not know everything. But this is about highlighting the important things to you, so that you know where to focus on, okay, especially with paediatrics. The only other thing, can I encourage you, when I ask you a question, if you're able to, just say the answer out loud. OSCEs is all about talking, and we need to start getting you to say the sentences that you would say in an OSCE. Practicing, if I ask you what is the definition of XYZ, say it out loud, not on the chat obviously, but just get used to starting to form those sentences, because it will be invaluable once you start. Okay, so let's begin. I will assume that everything's going okay, unless Danielle, you stop me and tell me that people can't hear or can't see me. So my timer has started, or hopefully we can keep going. Right, so I want to know, how do you feel about paediatrics? Okay, do you want me to get the children away from you because they terrify you? Or, you know, you might go near them in PPE, you'll go near them if the parents are there, because then it's basically an adult's history. Or your grown-up child, they love you, you love them. So use your Menti code. Let's see if this is working, and let's find out how it is. Oh, now we've got some answers. Okay, we like peds. Joyous news. Oh, someone doesn't like it that much. Okay, so that was more positive than I thought, which is great news. Right, so at the end of the session, hopefully you'll know the key components of the peds history. You'll be able to differentiate between different respiratory illnesses. We're going to focus on respiratory and common presenting complaint, because otherwise it's just going to be too big. We're going to look at a vomiting child, and we're going to know how to prescribe fluids for children. Okay, take a moment, look at this picture, say it out loud, and I'm about to change the screen so you can type it. What can you see with this child? Okay, type what you could see. Sorry, the picture's gone. But you've got to look at it for a few moments. Okay, so you've got a moon face, kind of the circular face, some sunken eyes. Yeah, there was definitely something about those eyes. Flat nose bridge, hello, yeah. Epicanthal folds, eyes close together. Yeah, we've got a couple of epicanthal folds, low set ears. Small ears, yeah, perfect. Okay, so basically this picture is just to show you can get a lot just by looking at the kids, okay? So fetal alcohol syndrome possibly could be, yes. Just be really careful with giving a diagnosis when I ask you what you can see. So if in your inspection of your OSCEs, never give the diagnosis, just say you can see XYZ. So here's a nice little labelled picture. This is actually supposed to be a child with Down syndrome. So they've got the palpebral fissures, they've got the brush-filled spots, which are probably a bit small for you to be able to see, very short neck, protruding tongue. Okay, so that's just to get you going, get you thinking, and now we'll kick off with the main parts. So these are all pictures of me, apart from this lovely child at the end, because I felt bad using pictures of other people's children. We can split paediatrics into neonates, so under 28 days, infants, so kind of after 28 days up to like a couple of years, younger child, a couple of years up to maybe like 10-ish, and then an older child, okay? And I've included this one, I think it was like maybe my 15th birthday on a summer camp, because I'm a summer baby, to remind you that they are still children, okay? You treat them as in engage with them like an adult, in that you ask questions to them when they're in the OSCE. If you've got a parent and a child, talk to the child first, okay? But to remind you, these are all the children. When you're thinking about, or you're going to OSCE, you've been given an age on the child on your little script beforehand. Look at that age and think, okay, what likely issue is going to be in a child of this age? And we'll come on to that a bit later, okay? So what additional questions do we need to ask in a paediatric history? Okay, so I'm assuming you know we're going to ask a presenting complaint. We're going to ask a history of presenting complaint. We're going to ask a past medical history. Oh yeah, here they come. We're going to ask about drug history. We're going to ask about social history. Yeah, so we're getting a couple of good answers here. IMS, pregnancy scan, prenatal history, developmental history. Anything else? Vaccinations, yeah. Time and PICU, very good. Social workers, perfect. Diet, yeah, I like that. We'll go diet as food, okay. Milestones, yeah. Animal contacts, yep, that's pretty much every person, to be fair. Wet nappies, someone got there. Perfect. I want to know, is that child hydrated? Okay, fine. Yep, yeah, we're doing well. Okay, so social worker, school, rashes, yeah. Okay, so I've got a little. So with regards to paediatric history taking, I don't know if you can see my mouse, but you know the left-hand side and you know the right-hand side. It's this middle part people miss, okay? Paediatric histories are not difficult, okay? It's what you know plus a few extras. And if you add the few extras after your past medical history, you're onto a winner. So every child, you want to know, are they eating and drinking and are they weeing, okay? So the way that you can ask that is, what would they normally eat or drink within a day, and are they having the normal amount? If it's less than 50%, you need to action something, okay? You need to be doing something. And you say, are they still passing wet nappies? Yes. Are they as full as they normally are, and when was the last one, okay? So that's hydration, because we need to know, does this child need to stay in hospital so that we can give them an NG, so a nasogastric tube or some IV fluids? We also want to know birth history. So the really simple way to ask this is before, during and after. So before baby was born, did they have any complications on the prenatal scans? No. How was baby delivered? C-section, vaginal delivery. Avoid saying normal, okay? There's no normal delivery. Were any instruments used? No. And after, did they spend any time in PICU, so the OSCEs, like the neonatal units? Have they been okay since birth? Okay, fine. Developmental history. The way you can ask this, do you think your child's progressing as you'd expect? Yeah. And then you can ask them more specific questions about the age. Drug history, as you said, vaccination, and you just want to know if they're up to date. Social history, people shy away from this, just go for it. I've done a peds job and I've asked so many people about social workers. People really don't mind. I've had one person get upset when I asked, and I've asked probably hundreds of children. So you just say, the question we ask everyone, do you guys have a social worker or any home visitors? Okay, and they'll say no. And then don't forget, when we're talking about social history, we also want to know how many other children are in that home. On a practical work note, I mean, you need to do it for OSCEs because that's important, but you want to know, if you're going to have to put in a safeguarding, are there other children involved? Do we need to get someone else out of the house? Have we got 6 children living in a 1-bed flat? Okay, So we need to know about that. Okay, so you've got the history taking. You're absolutely fine. Examination, you already know it. So you already know. I imagine that you can do a cardiac exam, you can do a respiratory exam, you can do a gastro exam. You've got to the final year. If you're here and if you're in 3rd or 4th year or something, you'll learn it. You know how to do the basic exams on adults. Literally all you need to do is just be opportunistic with children. You need to approach them, come down to their level, say, oh, look, I'm going to listen to mummy's chest when you've got your stethoscope, and then be, oh, now I'm going to listen to baby's chest. Ooh. So it's just about engaging with them nicely. There's not really any additional things. The only other examinations there are the developmental history and developmental examination and an IP, but there's really good resources out there about how to do them, so I'm not going into that now. So don't worry about the exam. If you're concerned about examining a child in an OSCE, please don't be. It will be fine. You know how to do it. Just be nice and friendly and smile when you do it and explain what you're doing. And if they're quiet, listen to their chest first of all, okay? Always listen to the chest first. Otherwise, you'll start to strip them off and they'll cry, okay? And children in nappies, always take everything off. All the clothes have got to come off, okay? I need to see if they've got bruises or a rash. Right, so case number 1. We've got a 9-month-old child presenting with a cough and a coryzal symptoms for the last 3 days. It seems to be getting worse over the last 24 hours, and dad has asthma, brother has eczema, okay? So 9 months old, ill for the last 3 days, getting worse. Have a think. What are you thinking of? Say to me 2, 3 differentials. Okay, what can you see? Do you see that picture? So it's obviously not of a 9-month-old, it's an older child, but still you get the point. What can you see? Ooh, subcostal recession. Yep, we've got it. Perfect, you know it. So if someone's recessing like that and they're little, I'd also expect their nose to be flaring, so in and out, nasal flaring. If they're very little, their head will be bobbing as they're working hard. And here, you see this is your trachea, obviously, and they get a tug, so I can't really do it on me without hurting. But this really draws in, okay? And when you've seen it once, you see it every time. So when you're inspecting a child from a respiratory station, you just need to say there's no increased signs of worker breathing. For this one, you would say there are signs. I can see evidence of intercostal recession, subcostal recession, and I would look for a tracheal tug, nasal bobbing, nasal flaring, and head bobbing. Okay, so our differentials. I've put all these on one slide so that you can see there's not that much in them and they're not that hard, but we're going to compare them so that you can kind of work out from the history what the diagnosis would be. Okay, so bronchiolitis, worst on day 3 and 4. It's caused by RSV. Symptoms that we're going to get are basically what we said, so increased work of breathing, so increased rest rate, recessions, nasal flaring. And then when we listen to them, we're going to hear maybe a bit of a wheeze and a bit of a crackle, okay? How are we going to manage them? So most of these children just need monitoring and can be sent home, okay? If they're eating and drinking, send them home, that's fine, and not in too much, not working too hard to breathe. If we're a bit worried about them and they're working quite hard, we'll do a VBG or a capillary blood gas, fill up the little tubes. If those show that they're retaining their carbon dioxide, then we need to action, okay? We need to put them on some high flow. It's a bit like CPAP. So if they're very unwell, we can also do a chest x-ray. But so when they say to you, how are you going to manage this bronchiolitis? You're going to say, I'm going to do supportive management. We'll give them a nasogastric tube if they're struggling to feed or are very breathless after they're feeding. We'll do a capillary blood gas to make sure that they're not retaining carbon dioxide, and we can start high flow if we need, and we'll start oxygen if they need it, okay? So that's bronchiolitis. So these are the littlies. The middlies, so remember that timeline. We've got viral induced wheeze. So basically they get an infection, everything becomes inflamed, smooth muscle contracts, causes obstruction, which causes a wheeze, okay? These children are absolutely fine between episodes. They have no symptoms. So when they're running around, they're not short of breath, and it's only wheezy when they're ill, okay? And the management, basically the same. So same sort of investigations. And in terms of treatment, oxygen if their saturations are low, and you give them salbutamol, ipratropium inhalers or nebulizers, depending on how unwell they are. So you can say, we would do back-to-back nebulizers if they're poorly, and we can do 4-hourly inhalers if they're well. This is what the wheeze plan is. So wheeze plan is kind of working down the inhalers and nebulizers. Okay, and then asthma. Essentially, you already know the definition. Cause, we're calling it hypersensitivity, but I know there's lots of different causes and lots of different theories around there. I want to highlight these to you. So how you're going to differentiate between viral induced wheeze and asthma. These kiddies are a bit younger, so they're usually under 3, can be up to 6. These children are a bit older, we wouldn't diagnose it in under 3s at all. They're going to get breathless when they're running around, have a nighttime cough, and there's triggers, and they're going to often be wheezy. So we'll give them a preventer and an inhaler, and we can give them some salbutamol or ipratropium if they're in hospital. I know that you know how to manage asthma as an adult. It's basically the same as a child, so I'm not going to run into that. And then, look, these are all the ways that things that you already know can come up in peds, okay? So you know how to interpret BBGs. Could you think about it? Could you explain to a parent how to use an inhaler? We can come on to that in a minute. And explaining asthma, just a diagnosis to them, that would be quite a nice station, an explanation, and a paediatric station, and then acute asthma management. So then another respiratory issue, inflammation of the upper airway. These children with croup, they have the seal barking cough. So imagine that's the seal barking cough. And they have stridor, so it's this noise. Like that. Sorry, it's not the best, but you know, you get the picture. These children are okay. You can give them some dexamethasone, but just monitor them. The thing that we're concerned about croup is if it's epiglottitis. So this is where we've got infection and inflammation of the epiglottis. Usually HIB, so Haemophilus influenza B. And these are in the unvaccinated children, okay? So you want to leave that child alone. They might be tripoding and they might be drooling, okay? And again, we can get dose calculations from her. Right, so just a quick question about asthma. An 8-year-old child comes into your GP practice with poorly controlled asthma. She's already taking a blue and a brown inhaler. What are you going to give her? So 8-year-old, not controlled asthma. Are we going to safety net and home her? Are we going to add a higher dose ICS, add in a LABA, leukotriene, or checker inhaler technique? Okay, we've got 11 of you who've said yes. So let's see. Oh wait, the results are hidden. Press H. There we go. Check inhaler technique. Nice. I thought I'd catch you out. Fine. So lots of you are saying check inhaler technique. Lots of you are saying leukotriene, LABA, ICS. It's a slight trick question because both of these two are correct. Okay, you're not going to escalate someone's treatment before you've checked they're actually taking it properly. And the next step on the algorithm with them would be to add a leukotriene receptor antagonist. Just have a think. You need to be able to explain these. So they're very simple. This is a spacer and a peak flow. Spacers, shake the inhaler, insert to the end, puff and breathe in 10 times. Don't forget about how to clean it. Wash it out with warm soapy water, leave it to dry. And peak flow, big inhalation, arrow to the end, 1 hard breath out, do it 3 times, take the average. Okay, again, not difficult, but a great station. And then this is just showing you that because this child was on an ICS and had a SABA, if they're still uncontrolled and we've checked their technique, we'd add in a leukotriene receptor antagonist, so something like Montuc. Okay, this is a 6-week-old baby with projectile vomiting, tummy's moving at rest. Have a think about what your key differential is. I'm going to keep going on this because I've actually got loads of slides and probably not enough time. So I'm not going to do any polls, but this is pyloric stenosis, okay? So they're a little baby, weeks old. They're having yellow non-bilious vomiting, projectile vomiting, and this is the blood gas that we're going to get. So they're going to be hypovolemic because they're vomiting out all their potassium. They're going to be having alkalosis again because they're vomiting out all of their acid of their stomach, and the kidneys are going to be exchanging protons for potassium. So again, we're losing that potassium. Okay, and the management is Ramsted's pylorotary. So differentials for a vomiting child, don't need to type them, just say them out loud. So you've got a vomiting child. Okay, So there's lots of differentials. I've highlighted some of the key ones. I'm actually not going to go through this with you now because I've basically put all of the important things that you need to know about each of these conditions. So intussusception, keyword, red currant jelly stool. GORD, key is conservative measures. Gastroenteritis, self-limiting, and cow's milk protein allergy, just work up the milk ladder, okay? Basically, this is just to show you that anything can cause vomiting in a child. Okay, this is the interesting one I wanted to get to. So we've got a child, let's call them a 15-year-old, and they are coming in because mum has said that they have been kind of withdrawn at school, they're not being very engaging at home, and mum's just a bit worried about their mental health, okay? So what do we need to ask in a teenage history? Oh, I thought I had an introductory one. Have a think, what specifically do you need to ask? Okay, so we need to do a heads history. So always, every teenage child, if this works for you, then use it, but you need to know about what their home environment is. Do they feel safe? Whether they're in school or whether they're in employment, what they do in their free time, whether they're taking drugs or drinking alcohol, whether they're having sex, and is it consensual sex? So if a 12-year-old is telling you that they're having sex, that is not consensual. If it's a 16-year-old, you want to say, do you have any sexual partners, boys or girls? Okay, where did you meet them? How old are they? Do you feel safe? Do you feel like you can say no? Oh, no questions from the audience. Oh, great, no questions. Perfect. So yeah, you want to find that out. And then self-harm, are they hurting themselves? Are they feeling particularly depressed or suicidal? In these consultations, you need to explain confidentiality. So you need to say, everything that you say here is between us, but is between you and myself and the medical team. That if I'm concerned, I'll have to tell other people, I'll have to escalate that and get the involved and relevant people. So always ask in an OSCE if the child wants you to ask the parent to leave, or if the parent will leave, always ask for the parent to leave. Chat to them a bit with them there. You'll find out more when the parents are not there. Okay. So depression in children can present slightly differently. It's a really, really big issue, which is why I've included it here. I see a lot of children who feel depressed. Sometimes it can be that they're irritable and withdrawn. But the key things to look here, so these risk factors are not difficult to have an educated guess on. Diagnosis, the same as adults, but can be a little bit more discreet. Is this management? So the things that you can ask and ask for in an OSCE, if they say, how do you want to manage them? Do not jump in with medication, okay? You want to say, I want to follow them up in 2 weeks. I can give them some information about psychological therapies. We could try some CBT. I'll talk to CAMS. I'll get the school involved, and then I'll think about fluoxetine, okay? And always assess risk in these children. So are they a risk to themselves, to others, or are they a risk from others? Are they a very vulnerable child? Okay, so that was the case, but the story continues because this child was a bit withdrawn, but as they were leaving, the mum goes, oh, and she just wheezed all the time. And then the light went off in one of my colleagues' head and was like, oh, let's do a BM, as we were in GP. And the BM was 25 and the ketones were 3.4. So what do we have now? Say it out loud because I'm sure you know. A diabetic ketoacidosis. Okay, so the diagnosis is the same. What are the symptoms for DKA? Other type, and I'll press this thing. Ooh. What age would you ask parents to leave? Good question. I would say kind of teenage years. You don't need to ask others. And let me see. I've answered that one. Answered. Do you only do heads if you're concerned about mental health? No, do it for all of them. Okay. Do it for all of the teenagers, really, if you have time. It should be pretty obvious. Whether you need to ask a heads history. And actually in a lot of it, you'll have covered it in your normal history. The only thing you need to ask about is relationships. Because in your normal history, you'll have covered it. Signs of DKA, perfect. Abdo pain, pearl drop breath, vomiting, tiredness, ketotic smell. You've got it, you know DKA. Oh, does that work? Yeah, okay. Oh, so DKA management is with fluids and insulin. If you have a DKA in your OSCE, you're going to say, I would have an A to E approach. I need a blood gas to confirm the diagnosis, because you want to see what the glucose on your BM is, and you want to see whether they're acidotic. You'd want to do a full set of bloods. You'd want to look for an infection source, so maybe a urine dip, or chest x-ray if it's respiratory, and then go from there. Okay, and the insulin is 0.1 unit per kilogram per hour. I've added this in for interest just because it talks about fluid deficit and how to prescribe it. I'm not going to go through it now. It's from the Sheffield guidelines, because they were the ones I could find on the internet, but it's very helpful to work through. Okay, so take a picture of that if you need it, but we'll talk about normal fluids now. So fluids for OSCEs. I don't think they're going to get you to prescribe DKA, but they might get you to prescribe normal fluids. So it's all weight based. So you've got their weight. The first 10 kilograms, you prescribe them 100 mils per kilogram. The second 10 kilograms, you give them 50 mils a kilogram. And the third, and anything after the first 20 is 20 mils a kilogram. Okay, so take a picture of that if you don't, because it goes on the next screen. And then tell me, so we've got a child of 50 kilograms. What would you prescribe per hour as their maintenance? So I'll give you a moment. Okay. And I'm actually not going to get you to respond to this because of time. I'm going to keep going. So let's break it down. 100 milligrams a kilogram for the first 10. So we've got 10 kilograms, 10 times 100, 1,000. 50 for the next 10, so 10 times 50, 500. Then we've got 30 kilograms left, so 30 times 20 is 600. Add it all together, 2,100 millilitres a day. Divide it by 24. Do not forget this, okay? Remember my face. I did not want you to give them a total per day mils, okay? Think about it. They asked for per hour. Give me per hour, okay? So just always check it in your OSCE. Other emergencies to run through: anaphylaxis, meningitis, and sepsis. I've highlighted these here because the anaphylaxis dose is a little bit different. If the child's between 6 and 12, the dose is 0.3, so 300 micrograms of adrenaline. Meningitis, always think about it with a child with a rash. Always ask, is it blanching or not blanching? And sepsis is the same management in a child as in an adult, okay? Never forget non-accidental injury, okay? Always have a critical mind. And this is, it's for OSCEs because they might throw it in. I would be a little bit surprised if they did. But if they do throw in an unexplained bruise, then you just want to say, you have to inform the parents about safeguarding. So you want to say, we see lots of children, and so that no vulnerable children are missed in our system, we end up making quite a few safeguarding referrals just so that people can find out a bit more information and make sure everything's okay. We're going to put in a safeguarding referral for your child. I just have to let you know about it, okay? You're not asking for their permission necessarily, or I guess you are, but you're phrasing it in a way that's saying we're doing it anyway, okay? And then this is just a little summary of some of the bits and bobs we've talked about, and kind of rough ages they present. This is not a comprehensive list that you could make on yourself, just to kind of get your head thinking. What I'm aware that was a bit of a gallop through paediatrics. What I really want you to understand is things that are going to come up: probably the wheezing child, the wheezing or short of breath child, a vomiting child, and an acutely unwell child. One of those three would be what I imagine would be come up. I don't think it will be super abstract or super out there, but management principles are very similar. Have a structure, so always start with at the bedside. If they're asking investigations at the bedside, I'll do this. Bloods I would request are XYZ, and then management would be escalate to a senior because it's a child. Okay, and if you're not sure, you can just say, I would check the guidelines. If they say to you, what regimen of insulin do you need, and you can't remember that 0.1 units per kilogram per hour, then you say, I'll check the local guideline because that is valid and that is safe. All they want to know is that you're safe. Okay, so we've chatted about all of those things. I hope that that's useful. I am very open to answer questions. I think there might be a question slide here. I'll just check the Q&A if there's anything in there. Slides will be sent. We'll now can't get rid of the Q&A. And we've talked about what age are you concerned about pyloric stenosis? So in those babies, so shall I go back to the slide? Let me come back up. Wait for it. There you go. So 2 to 7 weeks. It's those little ones, okay. Can present a little bit later, but probably doesn't. Let's go back. Oh, I ended it. Okay. Any other questions?
It looks like there's one question on the Q&A that says, sorry, what were the 3 emergency conditions? If you could go back to that slide for that individual.
Perfect, of course I can. So it's meningitis, sepsis and anaphylaxis. Okay, I'd just be aware of the management and presentation of all those things. So anaphylaxis, swollen lips, wheezy, short of breath, the obvious trigger, meningitis, a bit of a rash. A bit of a rash, that's such an understatement. A non-blanching rash, temperature, unwell child, looks sick, and sepsis could present with anything, but basically children get tachycardic, okay? So an unexplained tachycardia is a big issue in paediatrics. You need to find out why their heart rate's up, so potentially a tachycardia and a low blood pressure, but kids maintain their blood pressure quite well. That'll be quite a late sign. Okay, I've talked to you for ages, so I apologise. I'll give you a couple of minutes to have a break before I start. I'm doing haematology as well. Oh, wait, where are we? Sorry, I'm not looking at these. Why do you get non-bilious? Because if you think about where the obstruction is, so you've got your stomach, the pylorus is here, well, this is the stomach, this is the pylorus, and this is the intestine. You're not going to get because it's blocked here, you're going to get the gastric contents and not the intestinal contents coming out. I hope that makes sense. I'm going to enter that as marked. Would they give us a real child? I'd be surprised if they did. Probably not. It's hard to get kids to cooperate. It's hard to get them to cooperate multiple times in a row. I don't think you would. What we got in one of our OSCEs was this woman who's actually scarred my mind. That she acted like a child, and it was the most difficult thing. So with your friends, pretend to be a child and pretend to kind of get the information out of them, because the actors really do top notch to them. They're very committed to it. Do I think paediatric heart conditions could come up? I haven't included them because I thought it would be more of an explanation than we needed in this OSCE day. They might come up, but I think they're less likely to come up. But this is just me and what I've experienced and what I've heard from other people. If they are, it's probably going to be something like a VSD, and the child probably would have a background of Down syndrome or whatever. So I would say they're probably more likely to come up in your MCQs. There they would come up. And then I answered that one. This is quite fun.
Sorry, Kirsty, there's some in the other chat as well, which was, what was the dose for adrenaline again?
So let me show you a handy app. So I'm not sure I can promote other things on here, but it's just an app and we use it in medicine. So there's the Resus Council app. Oh, I don't know if you can see it. So Resus Council, it's called iResus. You can click on paediatric guideline, click on anaphylaxis. So get this before you do your revision, and then it gives you the doses and everything. Look them up, but it's if they're between 6 and 12, it's 300, and if they're below 6, so 6 to 6 months, it's 150 micrograms. Okay, whereas obviously in adults, 500 micrograms.